Thank you, Guru sir. So my today's talk will be on step-by-step surgical approach for the fellowship. So I'll be focusing more on the VR fellowship. So as I'm saying now, Guru is the most important thing which any fellow or the learner should have in their life. And I'm lucky to have both these together, Guru Prasad. So thank you, sir. You have been most important person in my life for the motivation and kind of support you give to all fellows and juniors like me. Thank you very much, and thank you for involving me in your IC, and along with Dr. Apurva and Dr. Krishna Prasad. So Dr. Apurva asked a question regarding that patient. One thing I would like to tell Apurva is, Apurva, we also have to be a good patientologist. So that's the new subject. That is because many physicians are unaware of the behavioral and the psychological aspects of their patients. And that translates the physician's interest into the patient into the actual practice of medicine. And a newly designated field of medicine, which can be called as patientology, should also be established. But I don't think you should regret it. And in one or the other way, she will regret and she will come back to you. That's what I have seen in my 10 years of practice. So I'll not go into the details. So timeline for the starting the fellowship is the first 2 months, 3 months. You can divide it from 3 to 6, 6 to 12, 12 to 18, and 18 to 21. So in the first 2 months, I think most of the things Guru sir has already covered it, is observing in the clinic. You have to be a very good observant. A good observation is half done. And also try to shadow the seniors, like you can follow the senior colleagues or your senior fellows also, and try to follow the protocols. And one thing which Dr. Guru Prasad sir always used to tell me is, first, if you have not practiced well with IDEO, then make a dot like this, right? Make a dot like this and then try to focus your 20D. This should come to the rim of your 20D. And that is how you can start learning right from the wet lab training to doing it on the patients. Then, of course, the intravitreal basics injections, he has told it about the lasers and everything. So IDEO examination, what I feel is very, very important. The first 3 months, you should know about detecting the peripheral lattices, indented examinations, and majority of the things. And this is one thing which Guru Prasad sir always suggests is, while giving intravitreal injection, try to wear a loop in the initial few days so that you can get a magnified view. So in the 3 months, once your OT posting starts, so it's always better to get oriented with the OT. And most important thing I would like to suggest our dear colleagues or juniors is, try to learn the system first. So learn the machine. Most of the time I have seen, even after 6 months, they try to fumble to press which is the fluid air exchange button. So they try to get confused. So it's always important to first learn the vitrectomy machine, whatever you are using, and try to learn assist, especially in case of indentation, basic imaging, or electrophysiology, which is basic imaging picture, the electrophysiology. These are all the things we should finish it off within the first 3 months of your fellowship. And coming to the next is between 3 to 6 months, once you start going to the OR and you are pretty much oriented with the things and set up in the institution you follow, is always better to follow that. And this is a slit lamp laser examination. You should start pretty soon. And again, the ports, coming to the ports, I would like to go directly. You can see this video here. Of course, you know that well better, 3.5 mm in pseudophakic and 4 mm in phakic. What I suggest to my young juniors is not to use any forceps in these kind of cases. Even if you want to, then you can catch hold of the cannula, not the conjunctiva. And the placement of the trocar always has to be important. It has to be tangential, parallel to the limbus first. We have a guide there. And once it stops there, then turn it perpendicular, and your direction has to be in the center of the vitreous cavity. So that is how you can see here, there was absolutely no blood, no touching of any of the conjunctiva, tearing of the conjunctiva. And that's how it's always better if you start with. And second thing is placing and knowing the infusion is always better, right? So once you put in that infusion, you should always check for it. This was done by our fellow, and inadvertently it went into the subretinal space and it caused a CDs as well. So immediately I went ahead and did the choroidal detachment, and the choroidal detachment settled very well, and then went ahead with vitrectomy. So the next is, again, as I said here, this was again recently operated just 2 days back. You can see here the infusion, they checked it, and you can see the retina underneath that. So this is not the right way to go ahead, remove it, and again place it. This also had a CD. So it's always better to go in for the 6 mm cannula in these cases. that always prevents the intravitreal fluid or the fluid coming from the infusion to go into subretinal space or the suprachoroidal space. So another important thing in the initial few days of your OR is doing a silicone oil removal. Most of the fellows think that, oh, what is this? They gave me silicone oil removal. I didn't do any vitrectomy. In fact, to tell you, my dear fellows, silicone removal is a very skillful surgery. It's not just removing the silicone oil actively. What you need to do here is to remove it completely as much as possible. Of course, it is impossible to remove 100% of the silicone oil droplets. So what we suggest is to do a skimming method. See, silicone oil is lighter than water. It floats. So it is at the interface between the air and the water. That is where you have to place your cutter and try to remove this oil. You can see how the silicone oil is coming to the to the cutter. So making it, see, in case you operated in a case of 6/9 vision or 6/6 patient had vision, if they had a minimal droplets remaining, and they'll be the most unhappy patients. So removal of the silicone oil, doing it meticulously, doing a skimming procedure properly, and try to remove as much as silicone oil droplets is the key to a successful silicone oil surgery, removal surgery. Then a laser endophotocoagulation is always an important thing. So you need to know the judgment where you place your laser. You need not to be too close to the retina nor far away from the retina. Otherwise, you will not cause sufficient burns. What I suggest to our young colleagues is try to mark it first. Whenever you are doing a PRP, at the temporal part of the macula, try to mark it. And over the disc also, on the nasal part of the disc, try to mark it. Inadvertently, accidentally, you don't try to step inside. So marking while doing a complete PRP is very, very important. And of course, it's not a difficult job. Once you get a good orientation, once you get a good hands-on, once you know that you have a good tissue handling, you can do these procedures pretty easily. Coming to the next, this is again a patient of the coloboma surgery where the PFCL can be used. You can use it up to the edge of the break and then try to complete as much as possible under the PFCL itself. Nevertheless, you can do it under the air, but visualization might get compromised sometimes. So better to do it under PFCL. So vitrectomy as a systematic approach is very important. Actually, the core vitrectomy is nowadays the book says that it's an erroneous concept because it was performed when it was with a rotational cutter, according to Steve Charles. But nowadays we have modern cutters, high cut rate, fast fluidics, linear suction. So AVC can be retained, especially in case of phakics. The anterior vitreous cortex can be retained, and so that the cataract formation will not happen very fast. And especially you can avoid fogging in case of patients where you do a posterior capsulotomy. So this is another video where you can do a good vitrectomy. But one thing my mentor used to say is doing vitrectomy is not like stirring the stirrer in the cup of tea or when you mix it with the sugar. It has to be done meticulously. You have to go systematically around it. Wait for the time until the vitreous comes to your cutter. I've seen many of the fellows just going around and around in the vitreous cavity. That's not the proper way. Wait for some time until the vitreous comes to your cutter. So then you'll have a good peripheral vitrectomy. Then again, in 6 to 12 months, you can start doing a band buckle independently and try to perform PVD. Understanding the architecture of the vitreous, its attachment to the retina is very key in inducing the PVD. And initially, we always suggest to use an IVTA. It's a good stain for you to see, and always try to induce it around the disc first. Look at the margin. Sometimes I have seen that they hold the cutter opposite to the disc margin, opposite to the rim of the attachment. That way the vitreous is not going to come to your cutter. Holding it exactly when you have to feed that rim of that vitreous which is attached to the disc so that you can peel it very easily with high vacuum. Now in 12 to 18 months, then of course you can start doing a base shaving, basics of ILMP, tackling the membrane. And this while injecting a PFCL, one more thing is very important is try to direct that injection towards the disc. Don't try to do it on the papillomacular bundle. You're going to damage it. And secondly, don't put it away from above. Go inside the bubble and inject it slowly. In that way, you will have a uniform PFCL bubble. Sometimes injecting from the top, you'll have multiple bubbles and it will be disturbing. And always try to inject it till the edge of the break. Here you can see there was a retinectomy done in this case here, and the PFCL was injected up till the break. So coming to the epiretinal membranes, Robert Mashimer first started the ERM peeling, forceps membrane peeling. Try to get oriented with different kind of forceps you have. I've seen many of the fellows doing it with the serrated forceps, doing an ILM peeling. You have an ILM forceps, you have an end grasping forceps. You can use that to do it a much better job. So ILM peeling, again, you can do it at around 8 to 12 months, or after 1 year, you can start doing it. Most importantly, try to use these Challam lenses or the flat lenses, because you get a good depth perception and orientation will be much better. You get a good magnification also. And once you have that, you know that you are pretty much stable in your hands and you're confident of doing the initial steps of the surgery, you can venture into doing. This was the surgery done by our fellow, where you can see systematically trying to remove the membrane. Most important, one thing I would like to tell all my dear fellows is just removing the membrane is not important. Leaving the membrane is very important, because you should know when to leave. Otherwise, you will pick the retina. See here, so nicely that fellow is trying to re-grasp it, again come back, re-grasp it, pull, again come back, re-grasp it, pull. So in this way, you can have a complete sheet of ILM once together, rather than multiple times you are trying to pick it up. That might damage the retina. And again, sometimes when you have an RD like this and later on you want to do an ILM peeling, instead of removing the PFCL, you can always stain the retina under the PFCL, but make sure that you use very less ILM BBG in these cases. So next is segmentation and cutter delamination, cutter scissor delamination. There are two techniques, outside in technique or inside out technique. Guru sir, in 2 minutes I'll finish. Outside in technique or inside out technique, whichever technique you want, you can go ahead. Outside in was done by Robert Mashimer, and inside out, in fact, is always better, because the central retina is always thicker, and you can try to pull as much thick as membrane from the centrally and then go periphery as much as possible. So there are various types of segmentations and delamination. Here you can see the most important thing which I would like to tell all my colleagues, junior colleagues, is try to do a proper peripheral surgery first, peripheral vitrectomy surgery first. So it's nothing but doing a 360-degree truncation. So once you do that, see, you try to detach the connection from the periphery to these membranes. Once you do that, then you can tackle these membrane very easily. And you can see this whole surgery was done by the cutter itself. And Dr. Guruprasad sir always used to explain to us during my fellowship how to do a segmentation. Segmentation is nothing but when you have a bridge with two columns, cutting across the bridge is called as segmentation. When you cut at the pole of the bridge, it is called as delamination. Here you can see I'm trying to break this membrane into multiple pieces. Like how we do a phacoemulsification, how we do a multiple pieces of the nucleus and then try to divide it. Similar way you can see here multiple pieces can be made, and then easily with the help of the vacuum, you can start doing the delamination. There can be a conformal delamination, cutter delamination, fold back delamination. You can use multiple techniques once you are thorough with, and thanks to these modern gauge cutters, which does most of these jobs. And again, ROP laser is very important. Once you are after first year of your this thing, you can start doing an ROP laser. And then lensectomy, I'll not go into the detail of this. Fluid air exchange is again a very important technique. Here you can see. And most importantly is once you start doing the fluid air exchange, go near the highest point of the break first. Yes, I'm almost finishing. Try to get the air as much as possible up to the break at the highest level of the break. See here the retinectomy was done. And in these cases, especially in these giant retinal tears, all care has to be taken because you want to avoid slippage. And then come to the disc. I've seen many of the fellows, once it comes to the edge, they directly jump on the disc. By this way, definitely there will be a subretinal fluid coming underneath. So always try to drain up till the edge of it. See here, up till the edge of it, and then come to the disc on the posterior pole. So silicone oil injection is last 1 or 2 videos I want to show is once you're doing a silicone oil, the important thing I want to show here is you can see here, you can slightly inject more so that it goes into the infusion. Because sometimes when you remove this, there might be a leakage, especially when we use these trokars multiple times, there can be some leakage. So once you remove this trokar, now you can see here, the silicone oil starts coming down because that much of oil is lost, and that oil is going to compensate and come inside. So by this technique, you will avoid underfill of the oil, neither the overfill. If there is overfill, it goes back into this infusion. So if these underfill, it comes back. So this way you can avoid overfilling or underfilling, and you can see the optimum filling in this eye. So I would like to show my last slide is once you are comfortable with doing most of these surgeries, you can go ahead, try to induce the PVD. See here, this was again a recent surgery. I just wanted to show it where you can do induce a PVD or do the membrane peeling just with the help of the cutter itself. After 18 months or 2 years, once you know that you are doing a good surgery, then you can go ahead with the cutter itself, because as I said, the cutter does most of the job. But don't hesitate. Like I want to show this last video. In this video, don't try to do heroics with the cutter itself, because sometimes we might get tear because of the high cut rate and the vacuum. We might involve the retina and try to do a retinal tears. So here you can see, whenever it comes to periphery or you see that the membrane is very tightly adherent, never hesitate to shift bimanually. Use a good chandelier illumination and try to use a good the scissors, and intermittently you can cut it with the cutter itself. But always, you can see here, there's almost a sclerotic retina. The retina is very thin in the periphery. The vessels are sclerosed there. So in these cases, it's always better to use bimanual, because you have control while peeling this membrane. And then you can do a proper base shaving after injecting the PFCL. Of course, PFCL does act like a third hand as well. And then under the PFCL, you can laser most of these breaks. So lastly, in case if you don't remove the PFO properly, this is how it happens, the subretinal PFO. And again, you have to use a 42 gauge needle to remove this PFO. So it's always better try, because PFO is colorless. It's not just at the disc, even at the posterior staphyloma, that is where the PFO might be remaining. So make sure that you do a complete PFO removal whenever at the end of the surgery when you want to remove it. So I would like to acknowledge Department of Retina, my colleagues, Dr. Apurva and Dr. Suresh, my mentor, Dr. Guru Prasad, and our dear fellow, Dr. Karthike and Dr. Giriraj, who has helped me in giving these videos back to me. Thank you very much once again, sir.